Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
And this is episode 6. My name's Sean Heron. Instead of a little bit of quirky repartee between myself and Skinny Medic, just wanted to say that we're going to have a Firearms Radio Network meetup at the NRA annual meetings. This is going to be in just a couple weeks here. It's Indianapolis, Indiana, and the meetup is going to be Saturday, April 27th at 6:30 p.m. at Sun King Brewing. And if you go to Firearms Radio Network on Facebook, you can see the event and all that good stuff there. Skinny Medic, are you excited for the event?
I am super excited. I love the NRA show. It's a time to meet people that are supporting us, and then obviously meet other creators and stuff like that. So I'm super excited. I'm excited about the firearms meetup. So I'll be there. I'll have patches. I'll have stickers as long as I've still got stuff left as far as the swag stuff. But I'll absolutely be giving away several trauma kits and a first aid kit there at the meetup.
Very cool. That is amazing. All right, man. Let's get right into it. First up, we're going to recap because we've talked about the different phases of care, whether regardless of which one you go by, whether it's care under fire, tactical field care, and evacuation care, or direct threat, indirect threat, and evacuation. We've covered kind of those and what you think about in those, and you can see those in the previous episodes of this show. And also, we are up to C, which is circulation. So just for a recap, March stands for.
So we've got massive bleeding, and then we have airway, then respiratory, and then circulation, which we're going to cover today, and then head injuries and heat loss.
All right, perfect. So when we talk about circulation in classes and just in the March protocol, kind of what really are we talking about?
So this is it's a little bit tricky as far as the civilian protocols and like understanding is what's for, but basically we're going to look at the blood and maybe circulation shock, like how the body is reacting to the amount of trauma that it's received. Hopefully the body is still compensating and doing well for the amount of trauma it's received. But this is where we're going to kind of sit back. We've kind of covered the major things that are going to kill our patient. We've understood the March algorithm, which is the massive bleeding, the airway, and respiratory. So we've covered those three first levels of things that are going to kill our patient. So now we can kind of sit back, take a deep breath, and just make sure we're not missing anything, like anything glaring obvious that's standing out on our patient that we may have missed.
Yeah. So in the circulation step, like you said, there's not a whole lot that we can do, but there's certain things that will give us indications that we may not have done our job up front. Maybe there's still a bleed going. Maybe there's additional bleeds, and some of those things can kind of go on. So what's a quick way to evaluate, circulation or shock?
So for me, like if I have a patient who's still responsive, I will check for a radial pulse because it's kind of weird that I start grabbing at your neck and feeling for a carotid pulse. If you're awake and talking to me, it's just kind of awkward. Mm-hmm. But if you're unconscious, I'm probably going to be near your head anyway. So I can run my fingers along your throat, where your voice box is, around this little crease right there, and I can feel for your carotid pulse there. But if you're awake and talking to me, I'm going to grab your wrist on your thumb side, and I'm going to feel your pulse there. Kind of gives me an idea. I may not necessarily be counting it immediately, but I can figure out in my head, okay, that's really fast, or that feels about right, or I don't feel it at all.
Yeah. Now, first off, the average pulse for just a normal everyday adult is going to be between 60 and 100, something like that. And the way people count pulses is they just take it for about 15 seconds and count the heartbeats and then multiply by 4, or you can count it for 10 seconds, multiply by 6. It's pretty easy and not too complicated at all. But generally, if you feel that pulse, it's usually a good indication. And that's that radial pulse at the wrist, thumb side, outside that tendon, just a gentle press with your index finger and your middle finger. Don't use your thumb, but those two fingers will give you a good idea. And if you feel a pulse there, it's a pretty good indicator that they're not in shock yet, correct?
Right. We feel a pulse there, and you said 15 seconds, 10 seconds. Like if you're not really good at math, you can even do it for 30 seconds. And if you're really slow, you can just do it for the full minute. But like, I don't know if I can multiply something by 6. I'm like trying to think in my head, like, all right, but I just use multiply by 4. So I'm like, multiply by 6. Oh my gosh. Like I'd have to get my phone out. But yeah, like if we know that we have a radial pulse, we have a decent blood pressure somewhere between 80 and 90 systolic being the top number, diastolic being the bottom number, which really can't feel. But that top number, systolic number, is what we're worried about at the moment as far as this trauma patient. So if we have a radial pulse, typically we have a blood pressure somewhere between 80 and 90 systolic, which means that they are probably perfusing their brain, getting enough oxygen and blood supply to their brain that it is functioning. So that's the main thing we want to see here is we want to make sure that we can keep their blood pressure up high enough to keep their brain still functioning, because the brain uses a lot of oxygen, it uses a lot of sugar. So we've got to make sure that we're keeping that functioning.
Yeah, definitely. Let's talk just about a couple different pulses that you can take. So radial is kind of the go-to, and being able to get that radial pulse means that they probably haven't started to shunt blood flow because they're fully in shock or anything like that. But there's a lot of other places. You mentioned the carotid, femoral artery. Can you get a pulse there?
Yeah, like that's another one. It's super difficult to feel, especially if someone's got clothes on. So you kind of have that awkward time here where you're going to have to put your hand down their pants and kind of feel down in that love crease. And they've got a femoral artery pulse there. It can be difficult to feel, but if you've got somebody who's unconscious and they're in shock, like you were saying, the radial pulse, we know that the blood's still shunting and it starts to pull in from the arms and the leg, pulls into the core. So if we're starting to lose those pulses, we can kind of start finding other places. And the femoral artery is a good site for someone who's unconscious. Like I said, you run your hand down, feel in the love crease, and you're going to feel a pulse there, hopefully.
Definitely. So carotid, femoral, radial, there's on the foot, there's one, if someone gets their arms blown off or something like that, you have to go somewhere else. The dorsalis pedis is on the top foot, big toe side.
It is like, that's a difficult one. So I
Definitely.
always recommend, if you do find that one, take your Sharpie out and write an X on it. Because that was a difficult one. Like you're trying to feel and you're like, oh, I found it. Put an X on their foot and make sure that way when you go back to reassess that you can find that one again.
Nurses find that one so quickly. They're like masters at it, but yeah, I suck at it.
Yeah, I struggle with, like, if I have a patient who's got a broken leg or something like that, and I'm trying to feel that pulse, I'm like, all right, shh, everybody stop talking. I got to feel this. And so I'm like, stop talking. I need to, like, it's got to be quiet. I got to hear this. And as soon as I find it, I pull out a Sharpie and I write on top of their foot.
Makes a lot of sense. There's the popliteal kind of behind the knee, which that one's incredibly difficult to find, especially depending on individual physiology, like, how much fat is there, how much tissue.
Correct.
So the go-tos for me, radial is my number one because it tells me a lot quickly. I don't even have to count or multiply or anything else. And carotid, clearly. Any other places that you recommend or you think are interesting or worth talking about?
No, I think that's the major one. So I think those are all pretty well the major points. Like I said, if someone has an injury to the upper arms like that, then knowing how to feel a pulse in a leg is something you may want to have in your toolbox.
Yeah, 100%. And I mean, this is easy to test. It's easy for people to do on, a loved one or yourself. Like you can go find it and, figure out what the landmarks are of where that pulse is. And it's difficult on an audio podcast for us to show you, but you can find them on yourself and you can look up diagrams on the internet. And then once you find them, like go find it on someone else. And once you can find it on a couple different people, you're pretty much good to go, at least having a good idea of where they're going to be, what to expect. And by, taking the people around you's pulse with permission, clearly, no implied consent here. It's definitely good practice. And I think it's an important skill to have either way.
Yeah, just take them out to dinner first and then find their pulses.
Exactly. Especially if it's that femoral pulse.
Yes. Make sure you take her to dinner first and then try to find the femoral pulse.
You mentioned secondary blood sweep in the show notes. Is this about the time that you kind of run through that?
Yeah, this was for me. Like I encourage people to kind of go back because, like I said, you've hit those top 3. Now you're kneeling beside a patient, and you just take a deep breath and go, "All right, let's sit here for a second." And then, a lot of times for me, like I've found bullet holes in some weird places, like the armpit, some creases, like someone's a little chunkier. You lift up a fat roll and like, the holy crap, there's a hole there. The armpit is a big one. I had an experienced crew one time that was getting ready to load the patient up. And we kind of started a secondary sweep, and they'd missed it. That gunshot went right up on the armpit, and that could have easily been a sucking chest wound. We put a chest seal on it and it was fine. But, taking that moment, start from head to toe, working each section, feel the head, looking at your gloves, feel the chest, looking at your gloves, abdomen, pelvis, the leg, the arms, and then rolling the patient, looking in the back, just doing another quick blood sweep, just kind of looking just to make 100% sure you're not missing something that's obvious.
Yeah, 100%. So, I mean, we've talked a little bit about shock, and there's all kinds of different kinds of shock. Why don't we go through that a little bit here?
Yeah. There's shock is basically when you're getting inadequate blood flow to the cells. And this is where they're starting getting deprived of oxygen and things like that. So the body, this could be from a number of things. What we're talking about here is obviously going to be trauma. So you may get like the lack of blood is causing them to go into shock. But this could be from diarrhea. This could be vomiting. Any number of things, even septic shock is all forms of shock. And basically, the body is trying to compensate for this. And so your first stage of shock is compensated shock. And this is where your blood pressure stays the same and your pulse kind of kicks up a little bit higher. And this could be maybe you give blood and you weren't quite ready to do that yet. You give and then, or maybe you just lost 500 cc's for whatever reason. But that's where the body's like, you know what? I can fix this. I can overcome this. I'm going to speed up. That's the way I'm going to fix this problem. I'm going to speed the heart rate up. Maybe I speed my respiratory drive up a little bit, but the body's like, I got this. We're good. And then depending on the health of the patient, like I'm in the bacon belt, it seems like. So everyone has cholesterol, diabetes, high hypertension, high blood pressure, stuff like that. So those are all going to affect your ability to deal with shock, especially if you're on blood thinners because you have AFib, things like that, which is irregular heartbeat. So these numbers we're giving are kind of generic, but it depends on how good of health you're in, honestly. But at some point your body's gonna reach it where it's like, I can't do this anymore. Maybe that's 1,500, 2,000 cc's of blood. But at some point it's going to go, you know what? I can't quite keep up. And that blood pressure starts to fall down and it's not able to maintain a good blood pressure. And this is where your patient starts passing out. They're not able to sit up anymore. They were sitting up, they pass out and they lay flat. They are able to regain consciousness. But at some point the body starts to fall off. And this is where we're going to enter into stage two shock, which is decompensated shock, and the body's just not able to maintain it. And then ultimately, at some point, maybe 2,500 cc's, which is about half the blood volume. The average adult has about 5 liters, 5,000 cc's of blood circulating in their body. And we go into this irreversible shock. And this is the point where we've passed no man's zone. Like, it doesn't matter what we do. You have the best surgeon in the world working on you. You have just lost too much blood, and it's irreversible shock, stage 3 shock. And this could be a matter of minutes. It could be a matter of time before you go into this. If you have a femoral artery bleed, you're talking 3 minutes, you're bled out. Or maybe it's a smaller bleed, and it takes you 10 minutes to bleed out. But this kind of depends on the mechanism of trauma here we're dealing with. But ultimately, these types of patients who have major trauma need to be at a surgeon's table.
Yeah, 100%. That was a very, very good explanation. And
that was long too. I was like, man.
No, it was really good. And clearly for us as civilian medics, as civilian people with med kits and IFACs and all that good stuff, there's just not much we can do here. So recognizing these symptoms is hugely valuable. I had someone come through a class and, we talked about shock and all the different symptoms and stuff. And he went home and his wife had outpatient surgery a couple of weeks later. And when she got home, he noticed that she was showing some clear symptoms and he wasn't 100% sure what was going on, but he was like, this seems an awful lot like what we talked about in class. And that was shock. And he was able to get her there. And sure enough, she was internally bleeding and she was literally showing signs and symptoms of shock. So he was able to kind of recognize that and get it there. It doesn't necessarily need to be bleeding outside the body. It can be all kinds of other things as well. What are some symptoms of shock?
So we can have the blood loss, and then if you have external bleeding, you'll be able to see that. That's going to be pretty obvious. The large pool of blood, stuff like that. Internal hemorrhaging, is a lot to do with mechanism. How this accident happened. We can look at bruising. A lot of times, bruising on the skin, things like that, is going to be a late sign. But you can get some bruising across the pelvis, the abdomen, the stomach area, and those are all signs that you have internal bleeding.
Yeah, definitely. And a list from TCCC is restlessness, irritability, decreased state of consciousness, nausea or vomiting, drowsiness, confusion, pale, cool, moist skin. Most of those are also signs of and symptoms of hypothermia and stuff, but just, something to keep an eye out for.
And something else I talk about in this section is that impending sense of doom. That if you have a patient who has major trauma, they've been in a major event. Like, I'm not talking about the 19-year-old girl who has a hangnail, but I'm talking about the guy who fell 3 stories to the ground, the guy who got hit by a car, the guy who's got major trauma. If they tell you that they're getting ready to die, you should believe them. And you can call it whatever you want to, that it's God's intuition or whatever you want to, what your faith believes, but we know, like your body knows you are getting ready to die, and you want to make sure you're making peace. I've had several patients in my career that have told me, I'm dying, I'm dying, I'm dying, I'm dying, and then 5 minutes later they're dead. And so you got to believe them. Unfortunately, there's not a whole lot we can do for these patients, besides getting them to a trauma surgeon. But just understand that, if you have a patient who has major trauma to their body and they tell you they're getting ready to die, they probably are.
Very interesting. So, I mean, there is some stuff that first responders can do. And what's the general stuff that you guys talk about and really do when you have someone who is going into shock and you're on the ambulance and whatnot?
So, if the medics can do a lot more stuff than obviously what civilian responders can do. We have TXA is a drug that's coming along really well in the military setting. Starting to see in some EMS services like helicopter flight services, but TXA basically prevents the breakdown of clots inside the body. So we're trying to promote this clot process to get it to stop the bleeding. But the body's a funny thing. Like, it starts to break these down. These little fibers start to break down. So this TXA drug prevents that. So you're seeing a lot of times that this is going to be given for bleeding that we can't control. So like abdominal area inside the chest cavity where we can't compress it, we can't stop it. They'll give TXA, and that kind of helps with the clotting, this help control bleeding. A lot of services now are starting to carry whole blood, which is fantastic, because we have the ability to put blood back into the body, which is going to carry oxygen. Like when I first got in EMS, every trauma patient got 2 large bore IVs, and you got normal saline, which is salt water, and we just made Kool-Aid out of these people. And now we're like, man, we were killing a lot of people. We just didn't know any better. So now whole blood is able to get the blood pressure back up, and it's able to carry oxygen. And so with the IV fluids, we still carry those on the ambulance because it's the only thing we really have. But we try to do as little fluid as we can to maintain their mental status or maintain a radial pulse. We're no longer giving that 2,000 cc's of blood, 2,000 cc's of saline. We're just giving just a little bit. Maybe we give 500, but just enough to maintain them and get them to the hospital.
All right. So, I mean, it's even stressful for you guys when someone starts going into shock.
Exactly. I mean, because like medical patients are fun because I can fix them. Even in their living room, their workplace, I can try to fix them. With a respiratory asthma patient, COPD patient, I can give them medicines. I can CPAP them. I can fix them. Trauma patients, I can't fix them. They need to be to a trauma surgeon very quickly. And it's one of those things where we start as EMS, like we start trying to do all this cool stuff because we want to do cool. We want to do some cool stuff, but ultimately this patient needs to be at a trauma surgeon. So as civilians, I also talk about that if this patient is able to swallow, we don't want to compromise the airway, but there's nothing wrong with giving this patient water to help them. That's a slow hydration rehydration process.
Mhm.
But still, I mean, it's not going to hurt them to have that water intake and trying to help promote the body rebuilding those red blood cells and starting to rebuild itself.
Yeah, there's a bicycle rider that you did a video on, and the video's been going around the internet for a while, and he severs his femoral artery, and you can see him kind of drinking throughout the video. And I'm like, yep, just a nice slow, as long as he's not too far into it, taking some oral rehydration is not a bad thing.
Not a bad thing at all. And every time I do a class, I think like someone talks about civilians doing IV stuff, and I always discourage. I really do, because patients can be difficult. Now, we talked about what happens with the body in shock, that all the blood gets pulled out of the arms and the legs. So if you're a civilian responder, you're like, I'm going to start an IV on, I'm going to give them some fluid to kind of get their blood pressure back up. You're taking someone whose veins are completely flat now because there's no blood in them, and you're trying to start an IV. And maybe you started one in training, or maybe you started one 20 years ago when you were in the military. You're doing more harm than good. So I really discourage, and it's really the only way you can find some IV supplies on the internet, obviously, but I try to discourage people. I'm like, there's ways you can spend your money better on medical supplies than buying IV fluid.
Yeah. For a very long time, Red Cross, and I don't know if it's just urban myth or what, but raising legs above the heart, is this something that helps?
Yeah, like a Trinity-Ellenberg position was taught for a long time, and now there's like controversy on it. Like, does it really help? Does it hurt? I don't really think it hurts anything, but I don't know that it helps necessarily. Like I've done it, and I probably would still do it today if something happened. Like, all right, let's raise your legs up, but you don't have to raise them up super far. We taught just to raise their legs like 6 inches. Like, take a pillowcase, take something like a book bag or whatever, and just prop their feet up, and it helps supposedly get their blood pressure back up. I kind of talked about it when I was doing the compensated shock thing. We all know that person who's given blood and then all of a sudden they pass out.
Yeah.
And that's where the body's not able to compensate for it. So obviously, if you have someone who's lost a lot of blood, you don't want them up walking around, moving around. So probably the best thing is to lay them flat. Get on flat on their back. That's the easiest way for the body to perfuse the brain, to make sure the pressure is good, is to have them laying flat on their back. So even if you don't necessarily raise their legs up, but at least get them laying flat.
Definitely. And then in the Boston bombing and kind of the aftermath video that's out there, you can see people raising legs, but they've got them literally at a 90-degree angle straight up. Like, hey, you know what? The intent is there. I get it. That's awesome. But yeah, a little bit excessive and exaggerated maybe.
Right. And like I said, it doesn't take much. Like I said, I don't know this session is going to hurt your patient at all unless they've got broken legs and just causing so much pain. But, typically it's not going to hurt the patient to get them to elevate their legs a little bit.
Yeah, and one key factor there to keep in mind is if you suspect any kind of cervical spine injury or spinal injury, we're not moving their legs either. We're keeping them nice and stable, steady, and not letting them move so they can displace and make it worse.
Right. And then under circulation too, it depends on how much time you have. Like, if you're just trying to buy time and you get bored, like you're waiting on EMS to get there, or you throw them in the back of a pickup truck or whatever your case may be. I always talk about like getting a blood pressure too, having a blood pressure cuff, maybe not necessarily in your IFACT, but maybe in your vehicle kit, things like that, having a blood pressure cuff. And this is where we kind of talk about, look, if you're just killing time and you're like, I don't know what else to do with this patient, take a blood pressure. We can take our first blood pressure, vital signs, respiratory rates, and that gets us our baseline vitals. So we can kind of build from there. So say you take your blood pressure of your patient and the blood pressure is 100/70, the heart rate's 140, and they're breathing 18 times a minute. And a few minutes later, say 5 minutes later, you take it, the blood pressure is the same, and their heart rate now is 130. It's come down a little bit. The patient still, maybe they don't look quite as pale. You can see that you're trending in the right direction.
Mm-hmm.
But say now their heart rate's 150 and their blood pressure is starting to drop a little bit, you're like, this is going the wrong direction. And you can kind of trend your patient to see if the interventions you have done are working, or there's other problems going on.
Definitely. And again, don't delay evacuation. If you're going to them or you're taking them to the hospital, don't delay it for a lot of this stuff. Once you get the life-threatening stuff out of the way, like get them in there and get them to that next level of care, because in circulation and shock, we are running out of time quickly. So definitely don't defer movement just so you can document and do those other things unless you have the time.
Correct. Like that's the last thing you're gonna do. Like if you're just like looking around twiddling your thumbs, you're like, I just don't know what to want. I want to still keep looking like a badass, but I don't know what to do. Take a blood pressure, like do that. So, but yeah, absolutely. You know, and we kind of talked about it in the shock thing too. That you know, this patient may have minutes, they may have hours to be to a trauma surgeon. It just depends on how much damage they have. So, and we really don't understand that until we get them to surgery. So they need to be there quickly.
Yep, 100%. All right, that's all I have in my notes. Anything else there for circulation?
I think that's it. I think that's the only thing I have for my notes.
Okay, perfect. Now let's talk about a product of the week. You've got an interesting one that I've actually never seen before. What is it?
Yeah, so this is a tourniquet that's kind of making its rounds on Instagram. It's produced or being brought to us by Combat Medical. I actually get my CLOX. I'm a distributor for them, so I get my CLOX there. Combat Medical is the distributor for the U.S. markets for CLOX, so that's where I get my CLOX from. And they have a tourniquet that's the Tactical Mechanical Tourniquet TMT, and it looks like it looks kind of like a cat. Like I'm gonna say it, like it looks like a cat, but it's a little bit different than a cat. And they kind of opened up the gamut on Instagram a while back because they Combat Medical posted, said, hey, we had the recommendation of TCCC, and then nobody was like, no, you don't, not quite. So they thought they did, and then they're like, oh, sorry. So they kind of had to retract just a little bit. But in all intents and purposes, I know that the committee is looking at different tourniquets on the markets right now. And it's my understanding that they are going to make some recommendations later on towards the end of the year. So, you know, we're kind of looking forward to that, see which tourniquets they're going to recommend now for us. Obviously, the cat and soft T will still be there, but maybe some other tourniquets that are on the market may get the recommendation stamp.
Yeah, it's pretty interesting. It seems like it's wider. Is that true?
It is. So the cat and soft T are soft T wide are both about 1.5 inches wide, and this one is 1.85. So it's a little bit wider, but it's less than 2 inches. So they're trying to find that sweet spot there. And the wider the tourniquet, the less pressure it takes to compress down the muscle mass, to close around the artery, to close against the bone. But you don't want to get super wide, but you don't want to be super narrow either. So it's kind of finding that sweet spot. So they've went a little bit wider than the cat and soft T. The other thing that I like about it is that it has an audible click when the windlass is secure. So you know it's nice and secure, that it's not going to unwind on you. So I like that. It compresses fairly small again. The cat and soft T both compress down to 5 inches in circumference. I got fussed at because I said diameter and circumference. I got
me too.
Oh my good gosh, people. So yeah, I got fussed at. So make sure I use the right terminology. So I apologize. But yeah, 5 inches round, diameter, circumference, whatever. But this one is a little bit, goes 5 3/4, so still super small. Anything less than this range is probably just needs a pressure bandage, or you could use a SWAT T, something like that. But super small, and then it'll go as wide as 38 inches, and that's pretty doggone wide. So a max circumference, plenty enough to cover my chicken legs there. But the reason why I wanted to bring this as the product of the week, and let's look at it, is because it has a junctional plate that'll attach to it. We've talked about in the other previous episodes that junctional bleeds are a pain. Like they really are. Like they're tough. You can't put a tourniquet on them. You got to hold pressure. Wound packing is what you need. There are some junctional tourniquets out there. There's the Jet by North American Rescue. Sam Medical has one as well, but they're all complicated, for me at least. And other people have complained about them being complicated because we don't use them a whole lot, and they've got a lot of screws, Velcro, and they can be a pain to put on and get secured nicely. So if this does work out well for them, then this junctional plate will slide onto your tourniquet, secure it in place, whether that be a shoulder or a pelvis, turn the windlass, and it'll control that junctional bleed for us. So I'm interested to see that. I want to see some videos of it. I like to see some real data behind that. But it sounds promising. So we'll see what the committee looks like. And I think the last post I saw, they said the committee was looking at that junctional plate for like prolonged field care, stuff like that. So if we're moving a patient out, we can secure this junctional tourniquet as we're evacing them to make it a little bit easier on us. So I think the next few months will be interesting taking a look at this tourniquet.
Yeah, for sure. It's a little bit longer than a cat tourniquet, a little bit wider than a cat tourniquet, goes a little bit smaller, but I think it's pretty cool. And one other thing I noticed, which is so weird to me, that it's got an indefinite stored shelf life as opposed to the expiration dates on cats.
Yeah, I saw that. I was like, that's okay, whatever. But
I know.
it'll be interesting to see. Like I said, I think having a windlass on a tourniquet, it's almost a must, especially on legs, things like that. Especially if you're trying to do it one-handed application. So I think there is no perfect tourniquet on the market. They all have their issues. So it would be cool if we could see the perfect tourniquet come out on the market. And I'm not saying this is it, but eventually.
Yeah, for sure. That junctional plate, are they even selling that yet? Is that a thing that exists, or it's just kind of being talked about?
I think it's just being talked about right now.
Cool. Yeah.
So I hope to have one soon, and we'll be talking about it more here on the show. And then I'll do a review, of course, on my YouTube channel, Skinny Medic YouTube channel.
Very cool. That's pretty exciting, man. And what do they run, like $44.95, something like that?
I think so.
Or actually, hold on. I'm looking at Combat Medical, and they're $29.95 for the CMP tourniquet. So same price as a cat tourniquet.
Yep.
All right. Very cool. I'm very interested to see what the committee comes back with and tells us.
Yeah, like the good thing about that is when the committee comes back and they give the recommendation, they're going to have plenty of data and research behind it. So you can kind of understand that what they're showing is, going to be good for the market.
Yeah, I did have one other question. So on a cat tourniquet, you can turn it clockwise, or you can turn the windlass clockwise or counterclockwise, and it'll fit in because there's two sides to the clip. But the TMT looked a little bit different. It looked like you almost had to turn it clockwise so it would pop back in that plate, because I was thinking if there's a ton of pressure on it, it might pop out of that bracket. Do you know off the top of your head if that's the case, or is it both ways?
Yes, I actually talked to him on the phone last week because I saw the picture and I thought, do you have to turn it one way? And on the phone, they said you could turn the windlass either way.
Okay.
So I hope to have some of those in our hand soon. I'll get you some as soon as I can. But they take a look at them. So, but yeah, on the phone, the rep said you could turn the windlass either way.
Cool stuff. This brings us to the point where we talk about after action. There was a video that was posted in one of your Facebook groups, in the Skinny Medic Facebook group, and I watched it. You watched it. Why don't you give us a kind of a brief rundown of what was happening?
Yeah. So the video got posted in my Skinny Medic Facebook group, and which happens a lot. I'm like, I love watching them, and I'll kind of go in there and comment. But this one is a gentleman who's gotten stabbed, I think like 7 or 9 times. A lot, all in the torso. It looks like he's laying face down on the ground, and this guy's recording it, and he's holding the pressure the best he can. And like, I first blasted the dude. I was like, dude, you're trying to, like, you're recording, like, do some work, like, do some medicine.
Yes.
But apparently he's recording on a laptop and not a cell phone. But he is screaming his head off, like, minutes to call 911. Someone get help. Someone get help. Call 911. So he's doing patient care. But this whole time, this whole podcast, we've been talking about circulation. Like, we're not moving to the hospital. I'm like, we got to get him to the hospital. We got to figure out some way to do that. So, but it's got tons of good potential to take a look at.
Yeah, it definitely does. And that was my initial response too. I didn't even realize he had a laptop. But yeah, he keeps like going, and it looks like he's adjusting the laptop and kind of moving it around to make sure it's getting good angles and whatnot.
Which is super important. While you're doing good patient care is to get your best side for the camera.
It is. But so stab wounds like that, penetrating trauma, and it was to his back and side. It looked like there's a lot of organs inside there that can cause a ton of bleeding and damage. And he's putting as much pressure as he can on, and he's kind of moving the pressure around. And let's talk real quick just about that bedside manner kind of thing. He says that he'll take the shirt off or whatever, and then says, "Oh shit." I was like, well, okay, well, this guy's probably going to be panicked a little bit.
Yeah, I'm like, you never want to hear that phrase come from your first responder going, "Oh crap, dude, you're screwed." You never want to hear that. Like, that's not, like, when the first responders gasp when they see something, like, that's not good. So yeah, the bedside manner, the language is pretty rough, and I get it. And like, he's in a stressful environment, but I'm like, dude, calm down, take a deep breath. And I'm not cracked. Like, he did a great job for what he was dealt with, what supplies he had, what he was. But I'm like, take a deep breath, calm down. You getting excited is not going to do a dang thing for your patient.
He said in the video that he was a combat medic, but I mean, yeah, he was calm except for when he wasn't calm.
Yeah. Like he was, like I said, he didn't do a bad job. Like, granted, I'm sure if someone would have handed him some Halo chest seals or some hyphen chest seals or some
Mhm.
Fox seals, he would have went to work. I mean, he's doing the best he can with improvised medicine. So no doubt there. But we've talked about scene safety in our podcast before, and that was one of the things I thought about. You have a victim who's been stabbed multiple times. Security is going to be a real issue. Make sure that whoever stabbed him, crazy ex-wife, crazy girlfriend, crazy dude, whoever, doesn't want to come up and try to stab you. So having that security is super important to make sure the scene is secure. Activating, calling 911. We know that law enforcement is going to come in and secure the scene. So, EMS is going to be delayed getting in here. So we need to make sure that we are, securing the scene the best we can. And then this, unfortunately, is what we call inside the box. So you have compressible and non-compressible bleeding. Compressible bleeding is arms and legs. We can control that with a tourniquet or 2 tourniquets or 4 tourniquets, whatever it takes. But you should be able to control that bleeding. But the problem comes when it's inside the box. We're not shoving a case of combat gauze in there. We can't stick our finger down in there. We don't have Miguel force, so we're reaching down there and grabbing stuff. It just doesn't work. And you can see blood coming out of these holes. So he's hit some kind of major vessel inside the torso.
Yeah, 100%. And dude was not using gloves, and I get it. Like he wanted to help. He was doing the right thing, and I am not criticizing him at all. But like you mentioned, scene safety, but also those biological barriers. It didn't seem like he knew the guy, and it is risky. It's just something to think about as a civilian out there with a little bit of medical knowledge and the desire to help. Just take into account people are dirty. There are a lot of bloodborne pathogens, and you take that risk if you put hands on blood without gloves.
Exactly. On my truck, right, the visor, on the driver's side visor, I keep a pair of gloves, a pair of trauma shears, a cat tourniquet, and a Glock 17 magazine. I'm like, I can fix everything with that. But that's the first thing I want to make sure I grab his gloves. Obviously this guy, I don't know if he was with his vehicle or not, but we do. You get excited and you're like, oh my, I want to help. I can do this. I can help. And you forget to put gloves on. And now you look down and you have blood all over your forearms, up to your elbows. And back in the day, like, that was cool. You're like, oh, yeah, this is great. I got blood all over me. But now we're like, that's gross. Like, you don't want blood all over you.
Yep, 100%. But yeah, good job to that guy. And I mean, he probably did help that guy to survive. Like,
absolutely. 100%. I think what the equipment that he was dealt with, what he was doing. Like, I'm not saying that I wouldn't be screaming my head off if all I had was a T-shirt to kind of help this guy. So props to him for being there and providing that patient care.
Yep, overcoming that bystander effect and getting involved. Hugely important.
Exactly.
All right, cool. I think we've covered circulation. We did our product. We did our after action video. I think that's just about it. Anything else you would like to share before we go?
I think that's it. Looking forward to NRA this year. Looking forward to hanging out with everybody. So super excited. My wife and kids, everybody will all be there.
Very cool. I cannot wait. It's going to be an absolute blast. And don't forget that is Saturday, April 27th at Sun King Brewery. We've got an entire place rented out for the Firearms Radio Network, and the shows that will be there. It'll be We Like Shooting, Gun Funny, Civilian Medical. I think AR-15 Podcast is going to be there. A bunch of other people. You can find out more about it at Firearms Radio Network on Facebook. And hey, don't forget to check us out. Civ Medical, CIVmedical.com is where you can go to find our podcast. But I buy all my gear. In fact, I just bought 2, they were the hyphen compact chest seals, and I also bought 2 of the compact I don't remember exactly off the top of my head. It's the compact compression bandages. I bought 2 of those as well from Medical Gear Outfitters. You can find that medicalgearoutfitters.com. And Skinny Medic has been kind enough to give you guys a discount. Use coupon code Civilian Medical, and it saves you 10% off your entire order. So whether it's just the stuff to build and put in your own kit or complete kits all built up just for you by Skinny Medic, you can find it all there. And I highly recommend that you do. Anything else, man?
Awesome. I think that's it.
All right, cool. Let's wrap this up, and we'll talk to y'all next week, and we'll see you at the NRA annual meetings in Indianapolis.
Find us and subscribe at civmedical.com.